Welcome to the procedures section of my website. So this is an introduction. Before you treat a person or assess a person, it's assumed that a proper case history was taken and a basic examination conducted beforehand. This will often include active, passive, and resisted ranges of motions of the various joints. So in regards to testing, each test is performed like any other orthopedic test you're familiar with. And they're all based on the patient's response. You have to listen, look, and feel for that. Even more so, you have to encourage the patient to give an honest response and look into their eyes if possible. The number of tests that we do far exceeds those found in any orthopedics or neurological tests. We deal with bone, enthesis, fascia, tendons, ligaments, joint capsules, muscle, dermis, subdermis, scar tissue, and collagen, blood vessels, lymph vessels, and nerves. We'll use the straight leg raise and the teres major tests here as examples. Straight leg raise, initially proceed with caution and not necessarily to end range, which I'll demonstrate shortly. Hold for a few seconds initially, always looking into the patient's eyes, always looking for the patient's response. After we do the first one, we pause for a few seconds, waiting again for a response to any physiological change. Then we repeat the procedure going a little bit further this time with the patient's permission. We always ask for ongoing consent during each procedure. During the test, not only do I listen for a verbal response, but feel their body for spasms, etc. As much as my body as possible is against theirs, so it's best to feel for any changes. I get a greater range of sensation that way. And I try and look into their eyes. If the condition worsens or an abnormal response is elicited, you should stop immediately and reassess the patient. Note, this test is passive motion. The practitioner could start with active motion testing or even include resisted. Okay, so let's start with the straight leg raise. Our common sense, as a matter of fact, much of what I do is so obvious you don't realize it, and you're probably using it right now, but we're going to try to elicit or try to separate some of these very obvious things. For example, in a straight leg raise, there's many things about a straight leg raise test that you do that just take for granted, like any of my tests or any of the tests that these procedures do. For example, when you do a straight leg raise, can I do a straight leg raise test with you? We're going to test for things. So if I do a straight leg raise test, I'll come this way. Okay, here we go. You don't do that. Nobody does that in a straight leg raise test because they're liable to go to the emergency ward right after that. You start slowly. I'm going to do a straight leg raise. Is that okay? Can I go a little further? Yeah, can I go a little further? All the tests are common sense like this. Just to give you an example, we'll deal with the straight leg raise in some sense. Suppose they have neuropathic pain from the nerve roots from the lumbosacral plexus. Suppose they had a previous disc degeneration problem or they had a herniated disc in the past and they got some pains down the leg. There might be edema or there might be an increase of pressure in the nerve roots where the blood's not getting to the nerve roots and have a sciatic kind of a pain. So I want to test for that. So I do something like a straight leg raise test and I look for their response. How do you feel? Now I want to elicit your pain. Does that elicit the pain? Do you feel it more this way? Do you feel it more this way? You see, I'm changing the straight leg raise test a little bit to find out which position elicits her pain. In that sense, it's still a straight leg type of test, the same philosophy, but I'm changing it just a little bit, trying to find out about her condition. So there's many, many different ways you can do like a simple straight leg raise test, but it follows the same path. Let's talk about another one. We'll talk about teres major now. Similar thing. Teres major is not so much of a long nerve test, though. Teres major, we might look for the enthesopathy, and teres major, maybe a swimming injury. A chronic person can't swim properly. Slide back that way, please. Back a little more. External rotation. Now, this time resist against me a little bit, move your arm up and let go. Just very little bit, up a little bit and let go. Okay, now, can I go a little further? It's kind of like a straight leg raise test, but this time we're working with teres major. And lift up a little bit and I do a muscle Always looking for a response. I look into her eyes. It's very important. I encourage her. It's very important. I encourage her to give me a response. As a matter of fact, the rapport that I have with the patient is very important because if they're shy or they don't want to give me bad news, they tend to keep the information to themselves, which is just what I don't need. So it's very important to get them to start talking, tell me the way they feel, and that. Okay. So that was a Terry's major test. You notice I included some long axis traction in there as well. Every test varies according to the patient's response. They kind of fine-tune so we're hitting exactly the right target spot, and everybody's different, so no two tests are rated the same. Scope of practice. You guys are responsible for staying within your scope. For example, you can load a hip and abduction when, when you load a hip and abduction when an insufficiency fracture is present in the neck of the femur, it's not really in your scope. This procedure is in the scope of practice of an orthopedist, but probably not in yours. And here's one more example. The position involves a lot of body contact in order to better feel for a response. Some of these positions may cross boundaries in your profession and therefore are not in your scope of practice. Treating. The treatment, so we talked about the assessment, but the treatment is actually the repeated application of the previous test that showed a positive outcome. Increased range of motion, less pain, a warming sensation, or improvement in function. Assessment and treatment work together, and now an assessment can be made. What test do we use? What test do we start with? That comes to like our clinical reasoning and our knowledge of epidemiology, where we like to test for like to start our testing for what's most likely to be the condition. What structures are we working on? Well, I like to say I'm working on the nerves, but obviously when I do like traction, I'm tractioning not only the nerves, but the ligaments, the blood vessels, the tendons, joint capsules. So there's many structures we're affecting at the same time. This technique is not really a panacea. It works on some people, but obviously not on everybody.